Are you all you're all able to see my screen now?
We can.
Yes.
If you put it in show mode, it'll be nice and big. Looks good.
Got it. Yeah, Tim, they did do a quick introduction of us, but yes, as I said, my name is Rich Bowman. Real pleasure to be here with you today. For purposes of this discussion, I have been working with MyHIN and our state HIE for a number of years, and specifically with Tim Pletcher, who runs our state HIE and has been a great partner for Blue Cross and Blue Shield of Michigan. We thought today what might be helpful, as Robbie said, is we'll do a little bit of a background on our state HIE, and then get into a bit on our pay for performance programs that we have in at Michigan, and as it relates to our health information exchange. So just a couple of quick slides that I thought I would hit. The way we've kind of built out our state health information exchange and how it correlates to our incentive programs. We worked with the state, this HIT commission. Tim and others were very instrumental in designing it and implementing and operating how this would work and how we would exchange information across the state of Michigan. There were several statewide groups. MyHIN has an operations and advisory committee that continues to meet and continues to provide input to this process and to information sharing across the state. A number of subcommittees that also look at specific topics such as social determinants of health. We meet regularly to talk about our physician payer quality collaborative, which we'll hear here a little bit as we go forward. And then that all kind of correlates to our Blue Cross incentive programs. We have a number of physician groups, physician organizations across our state, 6,000 practices, 20,000 providers. It's a number of them that we use within our incentive programs that as part of those incentive programs, we incent those groups and physicians to participate in our state HIE. And you'll see in a little bit here how that's helped us in a number of ways, but and particularly for purposes of this discussion, to get really good participation with our physicians across the state. Hey Tim, if you want to add to this or drive a bit more from the MyHIN.
No, the only thing I want to say is, the channel that you got to us to the MyHIN conversation was through Blue Cross, but the state of Michigan Medicaid and the Department of Health and Human Services really championed MyHIN, and so it's not there's no formal affiliation other than Blue Cross is one of the members on our board, and we work really closely together on a lot of things, but it's not a Blue Cross controlled thing. I want to sort of say that up front. They're a phenomenal partner, but what we have found is that the commercial plans and the state have slightly different agendas. And what we've been able to do is really align both of those agendas to reduce the burden on providers, to drive to sort of data sharing at scale, and really create this upward spiral where you do more and more with higher and higher quality data. But we have a great relationship with Blue Cross that just continues to sort of get better and better all the time. But I don't want anybody to think that Blue Cross owns us, or we could do this with a number of our different stakeholders and sort of tell the same kind of story. But they're a really good advocate for us, and a part of our model. It's really key that the health plans play a very significant role in what we do.
Hey, yeah, thanks, Tim. I appreciate that. I think that is key. We are a key participant. We've been able to take advantage of it and really see the benefits of it. But as Tim said, we do not own them. MyHIN is its own entity.
And the other thing is, and this is a message that I say to payers in other states who don't get this. I call it the black hat, white hat situation. And that is, if you think about it, some of these health plans have the power in the market to drive getting their own market share. What Blue Cross Blue Shield of Michigan has done is they've leveraged their market share to rise all boats. And what ends up happening as a return to Blue Cross is they end up getting 100% of their data versus just the 70% of the commercial market that they would get if they just did something themselves. Okay, and the wisdom of Blue Cross was they wanted all of their data, not just settle for that 70% of their commercial market position. And the model and the way that they engage raises all payer data availability, but it also helps them go to get that sort of up there at that 100% level of all the data that's available to them. And that's the differentiator in what we're doing here.
Yeah, and what we tried to highlight in this slide is really how we've grown this over time with our incentive programs, which really we started with admission, discharges, and transfers. We have some, I think there's some slides that I put in the back that I won't cover today, but we'd send out. We'll show you when we started with admission, discharges, and transfers. You know, it was a percentage of the hospitals in the state of Michigan. And then also the other variability was the quality of the data. And what we did over time with more incentives through our Michigan Blue Cross Blue Shield Michigan incentive programs, we incented the hospitals to participate. And we also, there was scoring, and MyHIM was instrumental in this, is in the quality of the data. And so as more participated and as the quality increased, that increased their availability for these incentive programs. So that was key. And we're now at I think 100% participation of the hospitals in the state of Michigan with submitting their ADTs, and the quality is improved immensely. So it's a huge thing. On the other side too, we list there this acres item, and it's really a way to attribute to a patient all the different identifiers of that particular person, and it helps us exchange data across the different entities, the hospitals, the physicians, and the payers. So that's been very, very helpful.
And it's probably good, Rich, if we actually, because we say acres, it's actually called the Active Care Relationship Service. And so basically we have a care map of everybody who's connected to the healthcare ecosystem and how they're connected. So all of the payers send us their enrollment files. All the providers send us their panels and their populations that they're contracted for. We are able to sort of eavesdrop on the ADTs so we can make associations for the hospitals, but we also can get people in different government programs like foster care through that kind of system. And so we're really able to create kind of a very comprehensive care map of where everybody is and how they're connected. And when you round all those rosters and lists up, you actually can get a very patient-centric view of how they fit into the healthcare ecosystem.
Tim, can you say what that acronym stands for again?
Active Care Relationship Service.
Thank you.
And we actually slip in and say acres a lot. And that's really, that throws people off a lot. And so it's totally a localism.
And just a quick question on this slide too. What is the timeline from 1 to 4? Has this been our last 10 years or?
It's about the last 6 years,
6,
probably
okay.
5, 6 years. You know, the first couple of years we had all the formation kinds of stuff. And in Michigan, we started with public health, and our immunizations were our first use case.
Yeah.
So we focused on the first year. So it's kind of ironic now.
Yeah.
It's great now, actually, though. But we tied meaningful use. That's why we say the state and the commercials work together. It turns out that at the time, the federal government and the state were uninterested in ADTs. They were very interested in public health data and immunization data. And so we tied that activity to meaningful use to get your meaningful use credit. we really spent the first 2 years onboarding folks to the immunization registry. And then as we kind of worked with the payer community and the hospitals, that's how we really landed on the ADTs being a very high priority. And if you remember at the time, the feds wanted everybody to do CCDAs. And that really wasn't something anybody wanted. And so they were pretty immature. And so we're taking these two very simple use cases of immunizations, pushing that to the registry, and then alert notification.
Perfect, thank you.
Yep. And as we said, we kind of progressed after that with the ADTs and this attribution file, and then improvement on data quality, and then expansion of the types of data that we send that gets sent through MyHand across the state. You know, the CCDAs that we mentioned, and then pushing data conformance for consistency and quality, expanding to skilled nursing facilities for the same type of data, and then ultimately for the providers to receive the data so that they can use it in their patient care. So all of this kind of stems around our with our incentive program, but more importantly with MyHand to be able to distribute and connect it to all those different entities. And then ultimately where we are now for interoperability, we worked closely with MyHand. They're our fire component of our solution, and do collection distribution of that data. So we've progressed, and there's a variety of use cases. I think I included it in the back of deck that MyHand does, and then ones that we as Blue Cross Blue Shield of Michigan take advantage of. And as Tim said, there's other players in the mix that use some of their other use cases, but this is kind of our journey from a Michigan perspective.
Yeah.
And then Tim, I threw in connected a handful of slides.
Well, we can go through these real quick. If you keep clicking, that'd be great, Rich. So, you know, MyHand state designated entity, you know, rationalize the madness. At one time, we had 8 different HIEs in Michigan. Okay. And so we're no stranger to the model of consolidation and the sort of progression toward what we now call health data utility. And essentially, you know, that just took lots of work across the state to sort of get to economies of scale and sort of, you know, make it so that there can kind of be one way. We very much are the curators of the ecosystem. And so you'll see as we kind of go along, we're not trying to tell everybody what their final tool is. We do have some tools. So we think of us like a floor versus a ceiling. And it's sort of our job to make sure that there's a floor across the whole state. But if people want to do very creative, innovative things, we don't hold them back. Next slide. So when we kind of think about the big 5 things that we do, we convene people. As part of our formal methodology, we bring everybody, you know, everybody's got a problem they want to solve. Not very many people are willing to sort of work to figure out what it's going to take to solve the problem. And we have learned that you can't sort of share data in the abstract. You really need to be very community of interest, very use case focused. And so we convene people to kind of take a big fuzzy problem. And part of our methodology is to boil that down. So if it was cybersecurity, you know, or identity, or, you know, most recently we've been looking at imaging, we actually write a white paper. We gather everybody, we go through a series of workshops, we write a white paper. You know, that we just finished this for imaging. We did another one for social determinants of health. But that process kind of documents what the community as a whole wants. And then it kind of drills down to what are the major use cases and what are the data sharing activities that are going to enable the highest value creating use cases. And we've taken that to sort of a high art where we focus an awful lot on use cases. And then in the middle, we got a bunch of shared services, the things everybody should have. You know, we call it the health directory versus a provider directory because it's a lot more sophisticated than just providers and NPES. The active care relationship service is really that care map of where people go to get care, who pays for their care, what programs they're in, et cetera. And yeah, we'll absolutely share these slides. I think we've turned them over. And then, you know, the MPI and something we call the common key service to sort of do matching. And then tools. We actually deploy a handful of tools. So things like Referrals Plus, so closed loop referral infrastructure. But we don't just try to promote our tool. We try to have a interoperable referrals use case, so that if Aunt Bertha or 211 or other folks want to participate, but they don't want to use our tool, then what we drive toward is a use case that's focused on how we do those interoperable things, and things like that. There might not even be a standard for, and so we kind of have to play with everybody and kind of manage the ecosystem to cobble something together. And then, as Rich mentioned, we do a lot of these conformance reports, and that's something we give back the data to folks. And then increasingly, we are brokering, not so much doing the data science and the big data on our stuff, but basically working with our trading partners so that we broker the insights that they have from their own big data activities. And we use that active care relationship service as a place to sort of keep what I'll call kind of maybe a dummied down registry, right? It sort of says, hey, this person is diabetic, or hey, this person is at risk for readmission. And then what we do is we say, if you want more information, follow this little pointer to get more detail. Okay, so we're not trying to solve all the problems as much as kind of serve up context to where everything is and how the patient fits. Next slide. We're really big on use cases, and we're really big on sticks and carrots. Okay. And I mean, when I say we're really big, we're really big. The key to everything we've done, the key to our speedy adoption. So it took us a long time to get every single critical access hospital with a daily census of 1, but it only took us 9 months to get 93% of all the ADTs. Okay, so we get the big kids all coming on board because they got written big checks as part of the incentive program from folks like the Blues, or it was a requirement in meaningful use from the state. So there's a question from Stefan. So is it correct to assume that any one entity, oh, it left me. All right, we'll go through and answer questions later. We'll try to get them. Next slide. So this is the way our process works, is we basically tee up these use cases. Sometimes it's a very formal process. We write a white paper, we identify the use cases. And then what we do is we basically work with the folks who pay for things, whether that's the state, the MCOs, the commercial plans, and they basically say, we're going to tie a use case participation to one of our regular population or value-based contracts. And I think our original point was, hey, maybe let's look at 10, 15% of those incentives that the plans are already paying, the state's already got in these programs. But what we're saying is the liquidity of information is so important that we want to tie participation in those use cases to some of those dollars. And what happens then is folks send that data to us. And then what happens is the money never comes to us. And this is an important ingredient in the formula. So what happens is the use case comes to us, the data comes to us, we run a conformance report on that data. And then we share those reports. We share them back with the senders. We share them back with the payers. We send them back with the state. And then what happens is the health plan decides, do they qualify for that incentive? So it's sort of like we're in the middle. We want everybody to get an A. Okay. You know, we want everybody's report card to go home and get an A, but it's sort of up to mom and dad, if you will, to see whether you get your allowance. And sometimes other factors are there. Maybe it was really hard week. And so, you know, you just decide that they're going to award a bigger chunk of it, or there's other things going on as part of that negotiation that happens. We're not involved in that other than just trying to say, here's the quality of the data and who's participating. And that's a great place for us to be because we don't want to be in the middle of that. Next slide. And it positions, we got everybody. I mean, with the level of participation and adoption is very important. We measure at the use case level. So, you know, we can kind of report out who's participating by which use case. There's about 37 different use cases in different states of progression. And we just increasingly try to push to get more and more folks doing things. And we pay attention at the use case level of who makes money. So basically, if you lose revenue to participate in a use case or to send some data, or you could, we don't charge you. You know, it doesn't make sense to say, here, send us your ADTs so you can lose revenue on your readmissions. It's a bad business model for the HIE to say, please buy my product so you can lose money. And so what we try to do is align those use cases where folks pay when they create value. So if you're going to use the HIE to deliver your lab results, where you make money delivering lab results, then we're going to charge you for that. But we're not necessarily going to charge you to be a good citizen and put your data in the longitudinal health record. Okay. Now, if you want to use the longitudinal health record for some of your folks, then yeah, absolutely. Right. So really try to match that value up at the use case level. Next slide. Just a quick few slides to show we got lots of coverage. You know, next slide too. One of the things that's interesting is we have all these pharmacies that basically comes out of our legacy for starting with immunizations. And we have a very strong IIS in Michigan. And we worked really closely with them, but this is a pretty differentiating thing we find, is that this sort of very pervasive pharmacy coverage. Next slide. So here's what we're talking about data. So the first thing is we basically say, send your data and you qualify for the money, and most folks get around to doing that. In fact, they do that very, very fast. Things don't need to take years when you do this model. You can do it within 1 year. You can get like big chunks done. The red is bad, and it's a hospital. These are all little hospitals, the quality of their data. Red is bad, green is good, okay? The deadline approaches for the next round, and you can see when, you know, we're sending these report cards back to the hospitals, getting closer and closer to the deadline. They have gone in and changed their business process to be able to have better quality data. To my knowledge, nobody in the country has got a better model to improve the quality of data. What happens is HIEs they just have a terrible time. They go back in and they put these Band-Aids on, and they try to constantly clean up the data. And people are always giving them grief about the data being bad. You know, why can't you fix your data? Why can't you fix your data? This model, because the CFO looks at these incentive checks and tells the IT people and tells the process people, hey, I don't really care. Just fix it. I don't care what Epic says. I don't care what is, you know, I want that incentive. And the system fixes itself. And this alignment of when it could be a policy lever where it comes down from the state, usually they use a little more stick action than carrot action. But again, we want everybody to be green, and we want you to get your money. So it's kind of a win-win system, other than, you know, it is a carrot or a stick. And so it is forcing people to do stuff versus just sort of hoping that they do the right thing. Next slide. All right, so I actually want you to talk through some of the mechanics here, Rich, of, you know, how it works on the payer side. You know, that was the lens from the HIE side.
Yep. Yeah, and Robbie and Timmy, I don't know how much time we have left, but I can hit these, and then if people have questions as we progress, we can always follow up. But you know, for the pay for performance programs, we wanted to ensure that our caregivers have actionable data, and you heard about how we move that data through the HIE. And so we supported the development of these HIE capabilities. You can imagine what it would have been like for us. I remember when we first started with the ADTs, it was one of our major clients who wanted us to have a better understanding of, at any given time, how many of their members were in the hospital, and we didn't really have good proactive ways to do that. So we started with the ADTs. And they happened to be my team. I remember estimating out what it was going to take to connect to each of the hospitals in the state, the different systems, and then all the contract agreements. And it quickly made a lot more sense to work with an entity like HIE. So for pay for performance, it made a lot of sense to use these statewide HIE capabilities. And then as we showed the quality of the data, we paid incentives not only to participate, but then the quality of the data. And that's progressed immensely. And as Tim showed, there's these report cards that get sent out, and we score, or we pay off those scorings. MyHin is just they're just explaining where people are at, and they provide the report card. So different use cases, as Tim mentioned, we're use case based. ADTs we talked a lot about. We're now exchanging CCDA informations. The common key, which Tim, I guess I'll let you talk about that a little bit. I think it relates to the acres thing, but I think this has a lot to do with a person identifier. But I believe that's a key piece.
Yeah. So the common key is a very different approach than how a lot of us do things in healthcare. The idea here is we assign a unique identifier. It's an additional unique identifier, and we propagate that out to everybody. So instead of you must talk to MyHin and we did the little magic Rosetta Stone where we translate your medical record number or your member number through our MPI and then out to somebody else's. What we do is we basically assign common keys to everything, and we push out these keys, and folks essentially keep that as an additional identifier. If they trust it, they can use it a lot to make their matching decisions on. If they don't, it's a very nice way to sort of passively spiral out another identifier for people to begin to rely on. And what's really nice about that is if two Epic sites use the common key, and they just query Epic to Epic, it'll bring back a shorter list of hits for them, and we don't have to be involved. If somebody does a big extract and gives it to an accountable care organization, we don't have to be involved, and it just helps them with their own matching process. And that's, there's nothing magical about it other than it's a lot of work. But it is a real nice way to sort of kind of bootstrap passively. Instead of fighting to the death over you all must use my number, you just add an additional identifier to the system, and to the degree people trust it and rely on it, they can add more weight in their matching algorithms to it.
Mhm.
Labs, we get all the labs except for like Quest. We have a big issue with Quest not properly sharing labs. It's just you got to go through extra hoops with them, but everybody else is doing a really good job.
And this we just try to show the major components. I think we kind of hit on those on the prior slide, but it gives you a nice visual of the different components that we're working on this pay for performance program.
And what's nice, not told in this story, is that the state innovation model, they had similar components, so that if providers were participating with some of the Blue Cross pieces and they were doing some of the state innovation model, they got credit from both directions.
Mhm.
And part of what we're really trying to do is continue to reward the provider base for participating in these sort of statewide all payer use cases. And that kind of just drives adoption. The better quality it is, the more available it is, the more you can trust to use it. The more you use it, the more you use it, the more value that gets created, and the whole system just kind of spirals up.
And Tim, what I'm hearing is that you have similar programs across all payers, or so Blue Cross Blue Shield is definitely, leading, it sounds like, the charge here. But are there other payers are doing it too?
Major payer program, and they have I think it's called PGIP at Blue Cross. It's called PIP at Priority, which is their provider incentive program. And so and then some of the managed care organizations, as the state kind of pushes down the responsibility to do things onto those managed care contracts, then they have expectations in their contracts to provide incentives to tie back to to reward providers for participating in use cases. And so you're really trying to align policy levers as well as these other more commercial traditional payment levers.
And you mentioned at the very beginning, I don't know if it was Rich or Tim, about 10 to 15% of the overall incentive is tied?
That's what we asked
to
for
metrics?
originally. It is, for a big health system, I think they can get like over $1 million, for some of these, but the thing is it builds over time. So ADTs they have to do now because the feds are making them, almost a decade later, but basically, you make it big enough so the CFO cares, and then you say you can't stop that, but now here's a new thing, and here's a new thing, and a new thing, and so each year you are building, and you're really, creating infrastructure over time that you can continue to do more and more things, and the folks who pay for stuff can kind of create value. We get a lot of use cases from the state that are good to do. Newborn screening. It's a wonderful use case, but there really isn't much teeth behind it. And so they pick up the tab, they pay all our bills to do it. We might even be able to push some resources to some of those motivated hospitals, but it might not line up as a priority for the commercial footprint. And so it doesn't get driven at the same level because maybe the state doesn't have the same kind of carrots to use. But over time, they put in some sticks that start to say, hey, you're not going to qualify for this if you are not meeting some of these objectives and some of these other use cases. And so we find some of the state things go a little slower, and there's a bigger portfolio of use cases, and so the urgency isn't there. We did some work in New Jersey. The commissioner basically tied, and at that point it was ADTs too, but tied some of the charity funds of availability to participation. And what was shocking is we saw the same kind of aggressive adoption curve like we saw in Michigan for some of our commercial payers. We saw it on the Medicaid side or on the state side, because they did a very similar approach to creating the right size incentive to make it worth people's while to make it a priority.
Great.
Yeah, I just wanted to note, Tim mentioned our PGIP program. That's been around even before our state AHIE was in place, where we do various incentives, and we do adjust those every year, as Tim said. And like he had mentioned, as we got progressive more with our state HIE and movement of data, those incentives became part of that program, but it's a subset of an overall incentive program that we have in place and have had in place for quite some time.
Fantastic.
Yeah, Claudia's jumping in here, and she's saying this model works, and yeah, we know it works. I mean, it hands down. You pay people, things can move very quickly, and that's the important piece here. But the key thing is you can also get them to improve their data process. And cleaning up good data is always better than just data.
Hey,
So
I think in interest of time, and Timmy, I think I took way too much time, and I apologize.
No, this is fantastic. It looks like this is a really great way to kind of sum up the impact you're having. So yeah, please, if you can walk us through this, and then we'll open it up for a few questions.
Yeah, Tim mentioned the 5 years, and it really was about 2016, and we started moving in the program, and you just see the progression over the last 5 years. And this slide kind of sums it up in terms of getting people to participate as we progress with this over the last really pretty aggressively over the last 5 years, but gives you an idea of where we've been and how we're moving along. But 100% participation with our POs and with the hospital. So it's really been a great partnership.
This is terrific. And I think it's just really interesting on the one slide of the use cases and also carrots and sticks. And as California is going through a statewide process of looking at how to create a statewide HIE framework, we are, as a coalition, focusing on the same thing. What are the use cases? Let's get down to the brass tacks, and also think about how do you incentivize and also enforcement or accountability. One question I have, and others on the call, please chime in, either raise your hand or through the text. But did you have any legislative action that kind of put you on this journey that you would say was super important? And, what would you call out for us to look at?
So basically, we didn't. Okay, we did have during sort of high tech, we were one of the state designated entities. Okay, and we had a standing HIT commission, which was put into legislation. Okay. And so that created kind of a framework to move down in this direction. But it had 9 trading areas, and it had HIEs in all 9 trading areas. And then under high tech funding for the state designated entity, that really created MyHIN, that really set everything in motion. There really hasn't been any legislation. We're now believing that it would be good to have some legislation for a health data utility. Because what we see is that COVID taught us that the world's much bigger than the EHR. And so as we look at kind of bridging schools and corrections facilities and a lot of community-based organizations, community-based organizations have a lot of energy right now, but what we know from the HIE market as a whole, that it's not sustainable. So these community-based organizations that are kind of popping up, while the people connections are vital and sustainable, the technology infrastructure really needs to be consolidated and get those economies of scale, or it's not sustainable. And just think cybersecurity. We have over 200 people. We have a huge infrastructure to really do a truly professional, high-grade job of this work. And you just start thinking about how hard it is to sort of propagate that out to all these little community entities, and you need to get to that scalability. And so we're really moving folks toward this idea of a utility across the whole state, truly multi-stakeholder, not thinking of it as the EHR as the center of the universe, especially because some of the interoperability things are getting solved there. But we need foster care. We need our social workers. We have so many other things that all kind of meet at the patient wherever they are, and it's not always going to be in a bricks and mortar facility. That we see that just truly becoming a utility for the state for reuse and cost reduction, and cybersecurity and privacy protection.
Mm-hmm. Yeah, and I see a question just came in terms of how are you working with CMS or other federal funding to be able to
we work really closely with Medicaid and DHHS, which is sort of one of those mega departments where human services across the board are all rolled into one entity. We very much try to serve that capacity, but we're also trying to talk what the Blue Cross, the commercial side of the house, wants to do, and trying to sort of go back to the state and go back to the payers and say, you guys are just creating these huge burdens on these providers. Can you standardize on how we do quality measurement collection? And so, we have a long-standing initiative to standardize, so we get all the supplemental clinical information as one big file, and then we distribute it back out to all the payers for their HEDIS measures. We're really trying to do this dance across all of the different stakeholders, and you enter corrections, you enter so many of these other services around the community that you got to tie them all together to really keep people healthy.
Yeah. Well, I think it's fantastic. Let's see, Judy, I see another question in here. Is it easier for you to get data out of the social services department? Oh, than it is in California. Thank you, Judy. Where you definitely, when you mentioned foster care.
No, it's not easy. No, it's not easy. I mean, none of it's easy. I mean, it's all just an amazing amount of work because everybody's parochial to their program. They've struggled so hard. They finally got funding for the thing that they want. And you're saying, we should all work together. We should pool our data. My technology people are actually really good, so you should use them, and you should give me a little piece of your gold to make all this be really cost effective for the people in the state. And that's a tough conversation for everybody. And I think it took things like COVID to really prove to folks It's
Yeah.
better if you have this infrastructure.
Right. Well, with that note, thank you. And we definitely are going to follow up. I'd love to see the white papers, especially the SDOH. That's definitely on our list too. And then also, I think the details, Rich, if we can get more details, of the pay for performance program, I'm sure
Sure.
many of the payers would be very appreciative and not have to start from scratch.
We're
So,
happy to send what the SIM people did too, because you might want to just see, because it reflects the state view of how that
yes.
same process works, and it's very different. But from a provider perspective, they just like, oh, it's good for me to do this use case. Great, I'm going to do this use case, and you're going to tell me whether it's green, yellow, or red. Awesome.
Well, thank you for doing what you're doing. And I think we keep thinking we're about 10 years behind. So maybe we can leapfrog with some of your leadership. So
Put the money in
again,
the right spot and give people the right incentives, and you can get stuff done, in months, not necessarily years. So
terrific. Thank you again. Thank you for your time today. And you're welcome to stay on. We're
Not
just going to go through some business, but
Yeah,
we'll follow up.
thank you very much. Take care.
All right. Take care.